as well. Okay, how about the impact on our services? Of course, over the past, the first 3 or 4 months from the pandemic, the patients went down. And if you're looking at this data showing that there is a slight decrease of the total number of patients comparing to the last years. And even for the pediatric surgery as well, there is 10 to decrease of patients since March to July. But by the end of the July and then August, it started to increase compared to the previous 3 months. So all of the data showing that the first 3 months from March to July, they tend to decrease total numbers of patients as well as for the interventions, the non-surgical interventions. Then we hope that we will increase total number of the patient starting from August or this September. So last year we have up to 130,000 outpatients clinic, including the subspecialist clinic, the heart failure, pacemaker, vascular pediatrics, and as well as for the outpatient for the surgery, both adult and cardiac. Then this is the total number of the intervention that we have already done. The total number of the coronary or cardiac catheterizations done is about 800 within the 6 cath lab. Total number of diagnostic 4,700 cases and about 4,300 interventions in a year. This is data for 2019. Mostly for the adult case is PCI, about 2,400 plus PCIs done in the last year, and the pacemaker insertions up to 500 cases, and TVAR and EVAR for the aortic case. Total is about 70 cases, but we have a lot of cases of the balloon mitral valve for those patients with the mitral stenosis. So the ablations total number is not so much, up to 300 something. The pediatric case, it is including the catheterization as well as for the ASO, ADO, and AMFU. I suppose it's up to 300 cases in a year. So this is the surgery. This the cardiothoracic surgery, 4 rooms, 7 doctors, total case about 1,800 case in a year. Mostly it's coronary artery bypass graft, the cabbage, followed by the valvular. Not sure this one, including the aorta as well as for the mitral valve surgery and the vascular surgery as well. The last one is for those patients with adult congenital heart surgery. The pediatric ones, we have 3 operating theaters, 6 cardiac surgeons, with the case of up to 1,000 cases in a year, both the simple or the complex congenital heart disease. I think that the last one that we have the emergency department with its 26 beds, with total number of patient admit to our ER about 12,000 cases, but mostly I suppose is regarding to the acute coronary syndrome. We have primary PCI. The last year's data showing about 479 primary PCR done, with door to balloon time is less than 90 minutes. The rest is patient admit to the heart failure and hypertension. So luckily we have a hotline, the emergency unit, which is actually the Jakarta Cardiovascular Care Unit Network System. So we supervise the hospital and primary health care in Jakarta, including the 80 hospitals and primary health care, which is connecting to our system. mostly is a dull case. So we have a one day care system for those patients admit for coronary angiogram as well as for the PCIs, meaning that they will spend only one day. Then we have one mini cath lab service which is located in the emergency department. Though, so we have 6 cath lab, one in the emergency rooms, which is that we hope that we can cut down the time for door to balloon time and for the primary PCI. So this is our excellent services by the year of 2019, including the arrhythmia interventions, the leadless pacemaker, then the pediatric with the implanter septal occluder, implanter ductal occluder, and the AMFO, the vascular, which is mostly patient with the endovascular aortic repair for aortic aneurysm and dissections. This is our setting of the intensive ward, both adult and the pediatric ICU. And we have the gymnasium for those patients after cardiac surgery or after the myocardial infarctions that they have a cardiovascular rehabilitation program. We have one dedicated building for the research. This is what we call the Indonesian Cardiovascular Research Centers. We running both biomolecular clinical research as well as the multi-centers research as well that we have already published last year, about 23 international publications. Last but not least, this is a dedicated building for the education and research. We train both nurse, technicians, doctors, and including the fellowship program for the interventional cardiovascular, EP, echo, as well as for the intensive care fellowship. Then we have our fellowship of the cardiac surgery, cardiac anesthesia, and the intensive care. So we have a close collaboration with some hospital, especially emphasize on the specific things like Taipei Fitran General Hospital. I think this one for the arrhythmia, right? And National Taiwan University Hospital. In China, we have a close collaboration with the Fuwai hospitals, as well as the second Xiangya Hospital in Changsha, and with Zhejiang University, of course. For the coronary, we have a close correlation with both Sonan Kamakura General Hospital and Tokushukai Medical Corporations. And with our neighbor Institute Jantung Negara in Malaysia, the vascular department, we have a close collaboration with the Clinica San Nicolas in Argentina. And for those with the surgery, as well as for the clinical cardiology with the University of Medical Center Utrecht in Netherlands. As we have a big country with the archipelagos, we have the cardiovascular networking from west to the east of Indonesia. So far, we have 24 hospitals in our supervisions, in our networking. Some of them with the cath lab plus the surgical competitions, they can do open heart surgery. And some just only have a cath lab for the non-surgical intervention. In Jakarta area, we have the Special Capital District of MAP for the cardiovascular emergency system. So this is a population of about 10 million people in Jakarta with the 740 kilometers square. So we have some hospital, which is the capability of the primary PCIs surrounding Jakarta with our supervision. So we can coordinating more than 80 hospital and primary health cares. Then we, once those patients got suffering from the heart attack, we can recommend to send to the nearby hospital, which is available for primary PCI, or we recommend to straightforward to send to our hospital. So this is our networking in surrounding Jakarta area for the cardiovascular emergency system. This is what we call the iSTEMI network in Jakarta and surrounding city. Last but not least, so far we have old building that we will expand to a new building. Hopefully for the next year, completed build our hospital. From 330 beds, we will expand to 550 beds. Hopefully that we will do a lot of things over the next 3 years. I think that we can in brief introduction about our hospital. Thank you very much for the giving opportunity.
Thank you, Dr. Iwan Dakota, for the remarks and the presentation. Today we have a moderator for this scientific session, Dr. Isman Firdaus, PhD. Dr. Isman Firdaus is the president of Indonesia Heart Association, senior consultant of critical care and interventional cardiologist, and also head of medical department of National Cardiovascular Center Harapan Kita Hospital. Please welcome Dr. Isman Firdaus. The time is yours.
Okay, thank you, Dr. Frida. Good afternoon, everyone, their viewers and their colleagues, especially our friends from China, from the Zhejiang Hospital. First of all, I would like to extend appreciation to the opportunity and of course your presence to this collaboration webinar. And of course, it will be hopefully will tremendous webinar for us and will be fruitful at the end of the webinars. We have 3 speakers attend in these webinars. In the previous, our President Director, Dr. Iwan Dakota, have give a comprehensive introduction. Our hospital, we know that National Cardiovascular Center Harapan Kita as the prominent top referral hospital in Indonesia, not only for locally, but also regionally and nationally. Of course, we hope in this webinar, we got some sharing from China and we collaborate each other for in the next future cooperations. For the first sessions, I would like to invite Professor Jian'an. Professor Jian'an Wang from Zhejiang University Hospital, the second affiliation hospital. We know the Professor Jian'an as the interventional cardiologist also, and the Vice President of China's Cardiac Society, and of course in the hospital of Zhejiang. Prof. Zhejiang, you can hear me?
Yes, sure. Yes, I can hear you.
Please proceed your presentations.
Okay.
Just a minute.
Okay, dear Dr. Dakota and all our friends online from Indonesia. Just now, Dr. Dakota gave a wonderful introduction to your institution and also your strategy for fighting the COVID-19. We learned a lot. Actually, we got a very strong impression about your very big cardiovascular program. It is my honor to, first, I would like to share with you about our hospital introduction and our hospital strategy to manage it, to fight the COVID-19 pandemic. First, I would like to talk about our hospital. Our hospital is located in the southern eastern part of China. It's one of the rich area. It's one of the rich cities in whole China. It's close to the, not far, it's around 500 miles away from the Wuhan. Our hospital is a quite old hospital. It was founded in 1869. It's a general hospital. Now we have 3,200 beds, and we have 2 hospital campuses. the old campus and the new one is not far away. It's around 4 miles, only 4 miles away, the two campuses. Last year, we admit more than, we had about than 6 million outpatient visits. 150,000 surgical cases done in last year. And I don't know whether you're familiar with the Gsai accreditation. We had 3 times Gsai accreditation. During the G20 Summit 2016, our hospital is the only designated healthcare institution for the G20 countries, including the former President Obama. Those departments are ranking very high in the China ranking system. Our hospital is based on the new ranking system set up by government. We are ranking the 9th in China, absolutely first one in Zhejiang province. So like those departments are ranking very high in China, like the pulmonary medicine, intensive care, cardiology, emergency, and radiology, neurosurgery, and neurology, and ophthalmology, etc., orthopedics, etc. And now I'm going to spend a little bit time talking about our heart center. The number of the structural heart disease the number of structural heart disease interventional procedures, actually we rank the top 1 in China. So including the TIVR procedure, like the mitral clip, like the left atrial appendage closure, this kind of the structural heart disease intervention procedures. Absolutely, like this one, like the angioplasty. Last year we have done more than 5,000, and including the coronary rotacyctomy, the pacemaker implantation. Every year, actually we do around 700 device implantation. The heart transplantation every year is around 30, not many, but 3 or 30 heart transplantation procedures. So all of those programs, absolutely we are top 1 in Zhejiang province. So Zhejiang province is, which has more than 60 million population, 60 million population. So Hangzhou is the capital city of Zhejiang province. Now I'm going to, now I'm going to talk about the transcatheter aortic valve replacement. I think maybe I will give a detail about our TIVR program, but this one just involving a little bit here. So we developed a Hangzhou solution. It's a kind of strategy for bicuspid aortic valve stenosis with a severe calcification. Also, the valves were mainly in Hangzhou. Is the first homemade device in China. Now our hospital gradually becoming the popular training center for overseas residents and fellows. Last year, there are more than 50 residents and fellows from United States and Canada. They spend several months in our hospital for hands-on training because several programs like the cardiology, neurology, neurosurgery, orthopedics, anesthesiology, and orthopedics. So those programs is approved by the American ACGME. So when those trainees, they came to our hospital, they can achieve the credit from ACGME. So now we are more and more the doctors from Western countries. They spend some time, they learn some of the hands-on, especially they like to learning some hands-on training, hands-on procedure training. Now I'm going to touch the second questions about the hospital management strategies during the pandemic, especially during the holiday pandemic. You know, in China, the pandemic is a hot center. The epicenter is in Wuhan. However, in other cities, like the big cities, back to that time, if we don't have the very good organization, maybe if you make you cannot properly diagnose the patient, maybe the interfering in your medical services so a lot. So the first time we established almost 10 that we call the task forces, different group, different function, like the COVID-19 prevention and control steering committee is the highest level. Then we have we call the prevention and control working committee. So under the working committee, there are 8 teams. The one is for the epidemiology and the quarantine. And then the other one, then the second one for the hospital infection control, they do daily inspection. And also we set up a medical expert panel to discuss to make differential diagnosis. We set up a human resources team, which organized, during that time, the infection disease department, they are always short of hand. So we reorganize our medical staff, especially we led the other department from internal medicine to support the infection control department. So we try to reorganize the medical staff resources. And then the medical equipment and the supply chain team, then the employee and the family care. During the hard time of pandemic, there are many medical staff. They are working in fever clinic. They are working in the isolation ward. So for those the staff, because they are usually after daily work, they just living in the hospital. We don't allow them to go home because we are worried about their family's safety. So the hospital provide some kind of the care for their family, especially for some of the elderly patient, not elderly member, those staff's family. So, in the March, our hospital sent a very big team, it's almost 200 medical staff to the Wuhan to support the Wuhan hospital. So at that time, the employee and the family care team, they provide a high quality service for those medical staff who went to the Wuhan. Looks so important. We set up an information center. During that time, there are so many informations. Some it looks like quite chaotic. So some are proper information, some are not proper information. So hospital set an information center to release the proper information to all of the staff, try to analyze what is correct, what is wrong. During that time, we are always shut off the PPE. So hospital set up a donation team, try to get the donation from the whole society to support our medical staff. Just like your country, Indonesia, in China, we emphasize in the early time, even the early time of the pandemic, we emphasize so much about wearing face masks. Because some patients we emphasize because the patients maybe incubation period, they may not have symptoms. We are worried about the aerosol or droplets in the eye may cause the infection. So now there are more and more evidence to support that the aerosol and the droplets can cause the spreading of the infection of COVID-19. Just like your institution, we build up a staff pipeline. I already mentioned about the human resources reorganization. We train those staff because most of them are not in infection control experts, so we train them. Then we let the infection disease department to control all of those staff pipeline. Usually every 4 hours each shift is just 4 hours. Initially, they take so long time to work. It's maybe very easy to be fatigued, may easy to catch the infection. So we shorten their working shift from the 8 hours, even 12 hours to the 4 hours. It's quite unique in China for all of the hospitals which run a fever clinic. I don't know in Indonesia, do you have a fever clinic or not? But in China, every hospital, the government, it's a kind of a regulation and a policy. So every hospital needs to set up a fever clinic. So every patient with a fever, the temperature is about 37.5 centigrade, they need to go to the fever clinic for triage over there. Then if they rule out the COVID-19 disease or rule out the highly suspicious case, then they can be admitted to different departments. This is our fever clinic. You say here, okay. So the staff management is looks like very crucial. Possibly as our staff, they always go around different cities, or they come back from the other epicenters. And we are so worried about they may direct to the hospital, may cause the other staff or even the patient be infected. Oh, until now, we still every day we want our every staff to report daily, to deliver daily report about their health status, about their transportation situation, where they have been other epicenters or other cities. So we emphasize a lot. It's around 10,000, almost 10,000 staff, different kinds of staff, including the doctors, nurses, even the general supply and administrators, even social workers. So even medical students and postgraduates, all of those staff or the students, because they are working or studying inside the campus, they need to deliver a daily report about their health state, about their transportation status, need to report to the hospital. So we check everybody. So we are worried about somebody may cause the infection of COVID-19. Like the fever clinic here, and same as yours, we measure the temperature, and PPE but now we are with almost 3 months we don't have any more patients. So PPE is plenty of PPE. But initially we are short of PPE. So you need to have a very good strategy for PPE consumption. So we set up different policies. We set up policies depending on the risk of exposure, depending on the severity of the epidemics, depending on the characteristics of patients, and depending on the availability of resources and the national guidelines. So we always change. We change the policy during the different time. We change the policy depending on those 5 elements. This we classify how dangerous the position, how dangerous is the post. And so the level 1 is the lowest one. Level 2 is the highest exposure rate. The level 3 is the highest exposure rate. So maybe for the most dangerous position. Just like yours, you can see from the entrance, and here's the fever clinic. For those suspected patients, usually we isolated these patients in hospital in different area. So then if the swab is negative, then we send them to the different department. If it's positive, if the patient get confirmed of the COVID-19, we report to the CDC. Then we send them to the isolation ward. So simultaneously, we do the contact tracing. And usually, we under the guidance of the CDC guidance, we do the contact tracing. We do the contact tracing. During the pandemic, our outpatient service dropped a lot. We persuade our patient now, if expect the emergency cases, we let them to, for the regular checking, we let them to delay their visiting hospital. We provide the online service. Even we give them prescription online. We prolong the prescription time, the insurance company, in China, most insurance companies belong to the government. So government insurance department, they allow us during the time of pandemic, they allow us to give the long 3 months, right? Even the long 3 months, as long as the prescription for those patients with chronic disease like the stable angina pectoris, hyperlipidemia, hypertension, for these stable patients. So allow us to give 3 months medications. So what is about surgery? So we just, during the time of the pandemic, we just suspend
new and screen name.
All of the elective surgeries, only perform the emergency surgery and some semi-elective surgeries. For procedure, during the whole time of pandemic, we even stopped the regular dental service. You know, dental service may cause a lot of droplets, easy to cause the spreading of the infection. We even stopped the dental care, but for emergency case still open. But we let our dental wear the PPE.
Oh,
So we control the visit a lot. In Chinese culture, usually when the patient, family like to stay with the patients, but we emphasize a lot. We control the visitors. Even one patient can have only 1 visitors. Here's the impact. Because of the pandemic, the impact on our service volume, you can see during the pandemic time, so drop a lot, the outpatient and the inpatient service. So we sent a team to Wuhan, and they stay there almost 2 months. So our team, they are doing very well in Wuhan. No medical staff being infected. It's 0 and no hospital infection of patient, without the nosocomial infection of patients. They didn't miss any diagnosis of patients. I think the end of the March, my staff, we work together, administration staff work together to load our book. It's a kind of guideline. So the name of the guideline is Anti-Pandemic Experience Sharing. We translated it into 28 languages. We work with, we put on the Alibaba, the webnet. Okay, so it's free for checkout. Now in China, the pandemic almost gone, but occasionally some place, maybe some cases out, but actually it's under control in whole China. Hopefully in the world, will be under control. So we need to work together to fight against our common disease. Thank you so much for your attention. I just finished the hospital introduction and strategies, our hospital for COVID-19. Okay.
Thank you, Prof. Jian'an, for your comprehensive presentations, especially for sharing experiences of COVID-19 management in your hospital. We hope we in National Heart Center Harapan Kita also will share our experience to manage the COVID-19. We aware that your hospital or your region nearby the epicenter of COVID-19 in Wuhan, right? So
yes.
we see also in our hospital, we still put masks, you see here, and we see in your hospital, your staff still use masks. So the situation still impact from both hospital, China and Indonesia. For the next sessions, I would like to invite the head of the critical care cardiology, intensive cardiovascular care department, Dr. Dafsah A, Juzar, to present it the COVID-19 management in Harapan Kita Hospital based on our national guidelines. Dr. Dafsah, please proceed your presentations.
Thank you very much, Dr. Isman, and I really enjoyed that first presentation by the Professor Jian'an. And I think COVID-19 came around March in our country, and we learned a lot and adopt a lot of regulation and also protocol from China. And I think we are very grateful that you share all your experiences. And now I'd like to also share what we do in our hospital. As an introduction, I think I would like to put how the COVID-19 in perspective to the world. I think in Indonesia, with total population of 269 million, we have 165,000 cases. And the total death is 7,000. And death per 1 million population is 27. So we are ranked, I think we rank 23. This is our archipelago. As you can see that we are very spread out, divided by the sea. And we can see that Harapan Kita is in Jakarta. That's one of the biggest red shadow there you can see. And then below us is Australia, and then on top is Malaysia and also Singapore. As you can see, Harapan Kita is in Jakarta, and Jakarta has 34,000 cases, 21% of the whole Indonesia. And if you can see the trend, the blue line is the confirmed cases, and then the green line is the recovered cases, and the orange line is death. You can see that we are actually on the rise. If I hear that in your place is coming down, but in Jakarta and in Indonesia as a whole, is actually we are still on the rise. So we still have a long way to go. With Jakarta cases around 34,000 and death about 3.2%. If you see the trend of emergency admission, as you can see, the blue block is 2019, and then the green block is 2020. And I also put at the top there that we have our first confirmed cases in March 14, and then we have our isolation ward in March 23rd. At the time, we are not actually taking a COVID patient, but once the patient arrives in our ED, we find it very hard to refer the patient, so we had to have our own isolation. As you can see here, that the cases admission, it's actually from March to April, it's dropped quite significantly, almost half the ED admission. And then at the time also, like you've mentioned, that we have to take care of our health provider, and also we have a lot of fellow, we have a lot of trainee, and also our staff. This drop actually, this is the beginning, and what we did is, since we have such a drop of patient, and then we also don't have a means of confirming the diagnosis by PCR, we have to send it outside, and usually it takes like 10 days. So at the time, despite the low admission, actually our ward is in isolation ward is actually full, because all the patients are waiting for the result. And then on the April 24th, we are able to do an in-house PCR test, which is, and then we start fully functioning again, and all the staff start coming in. So we can see here that from May to July, actually the ED admission increases. And we also, by 22nd of May, we are appointed as a referral for COVID, especially for patients with cardiovascular comorbidities. And at the same time, we also have a dedicated lab to do our procedure in possible or confirmed cases. In isolation ward, it's also include patient ICU isolation, but we have 159 cases patient, and mostly is a heart failure patient. As you can see, 1/3 of it is acute coronary syndrome patient, and then we have around 7% patient with septic diagnosis. As an etiology, mostly coronary artery disease, valvular disease around 24%, and then 5% is a congenital, grown-up congenital heart disease. In isolation, the mortality is, as you can see here, is quite high. It's 35 out of 159. And then out of the confirmed COVID, it's actually only 35, and then the 6 of them actually didn't survive. The cause of death in isolation ward mostly is due to metabolic and heart failure. Means metabolic means multi-organ dysfunction, and then also septic, and of course pneumonia as well. As you can see here, I've previously shown that our admission between March and July in 2020 and in comparison 2019, it actually dropped between March and April. So is the acute coronary syndrome cases. You can see here from March and April is quite drop, and then in May we have our dedicated, and we all start receiving patient. As you know, we have our network, and usually we are referred for patient for primary PCI. But before in May, I think we also adopt some of the protocol that have been done, which is we ask them to do a fibrinolysis instead of sending it to our place. And then starting May, we open we have our own isolation cath lab. So the case start increases, admission case for acute coronary syndrome. I'm sorry, this is a bit, maybe it's hard to read, but this is, I just wanna show that in the prior to June, before we have the PCR, we rely on our epidemiology form to triage the patient with possible COVID. So if the patient come to us criteria for suspect, and also we only check with the lymphocytopenia and also chest X-ray. So we're sending him to isolation ward until it's proven otherwise by swab test. And then I also like to show that our regimen for patient cardiovascular who came in with possible or confirmed COVID. Basically, it's comprised of hydroxychloroquine and azithromycin in combination, and antiviral when there is a moderate or severe symptom for a lung problem. And then once we have we do our own PCR testing, we become more, how do I say, it's not confident. We become more readily to accept more patient, and then it takes less time for the patient to be triaged to the isolation ward, which basically what we use here. I think it's not very complex. We use a laboratory for blood and also chest X-ray, and also the epidemiology form for possible of COVID. So we ask for their history of fever, contact, and also travel, and of course cough or even diarrhea. Here we see we combine if we find one of the criteria like lymphocytopenia absolute and also NLR above 3.13, and then we have infiltrate. We see an infiltrate in chest X-ray. We put the patient in a isolation ward, and all patients got triage before they went into ED. So we actually built we built another room or section to triage the patient who need further evaluation for the possible of COVID. But here we can see that if the patient is coming in STEMI, we do all these tests, the rapid test, lymphopenia, absolute. We take the blood test, chest X-ray, and then rapid test, and then we send it straight to the dedicated cath lab. And then after the procedure, depending on the lab test that comes out while we're doing the primary PCI, if one of the criteria is met, then we put them in isolation to have a swab test within 24 hours. And for non-STEMI cases, it's basically it's the same. What we do is we're not very aggressive in our center. What we do, we usually just do the high risk and very high risk patient for early invasive strategy due to the availability of room. And I think as in your place, we have a lot of mostly elective cases from out of the city. In comparison, I think the blue line is 2019, and then the green line is 2020. Pretty much the case is almost three-fourths from the 2019. And then while the STEMI and non-STEMI cases actually has gone up, but somehow the STEMI cases hasn't come up to our usual numbers. This is, as you can see here, that the STEMI case basically stay the same monthly, around 25 patients per month. And then in terms of door to balloon, we can see here that in April, before we have our own PCR and our own dedicated cath lab, our door to balloon is 209 minutes. And we managed to make it come down by the strategy that I've mentioned previously to 125 to 130 minutes door to balloon. It's not like our previous, since we have to take triage the patient before we do the primary PCI. That's actually delay a little bit. And then the other difference is, as already been mentioned, that we have a network in this pandemic. It's actually most of the patient coming is direct access hospital. It doesn't come from our network. That's probably, I'm not sure why, maybe because their cases also down as well, and people probably I assume people afraid to come into the hospital unless their symptom is unbearable. As you can also see the pain to first medical contact, since they most likely they like to go to a big hospital right away, or to our hospital. You can see that the pain to first medical contact is really high. The median is 600 minutes when it's usually only 360, although it's still probably high by your standard. And then from symptom to balloon time, our patient is, as you can see, is 600 minutes. So it's mostly, the median is almost 10 hours. In regard to early invasive strategy, actually the proportion of patient goes to early invasive is not any difference than what we usually do. As I mentioned, we do the cases, only the high and very high risk cases that got sent to the lab for early invasive strategy. And about the outcomes, the mortality for STEMI is 10% in 2019 and 12% in 2020. And for non-STEMI or non-ST elevation acute coronary syndrome is much lower. And as a complication, you can see here that heart failure is mostly the complication we can anticipate from the long time patient coming in with a median of pain to device around 10 hours. And in comparison to 2019, regarding major bleeding and also the need for intubation is actually in 2020 is the proportion is a bit less in non-STEMI, but it's higher in STEMI cases. So as a COVID-19 diagnosis in ACS, we have from March till July, we have 199 cases of STEMI, which only out of all of them, they have 4 confirmed or possible cases. And for non-STEMI, we have 373 non-STEMI cases. Out of the 373, there is 6 confirmed or possible cases. So in ACS, the possible confirmed cases is around 1.7%. But for the isolation ward, the confirmed cases around 17.4%. As mentioned that hydroxychloroquine is used, so we have our protocol that also adopted from ESC regarding how to initiate and to prevent arrhythmias due to a prolonged QT interval. Out of those patients who has chloroquine or azithromycin, the one that has chloroquine is have one VT complication, and then azithromycin has 6 out of 30, and then combination of chloroquine azithromycin is 20, 4 out of 20. Combination hydroxychloroquine and azithromycin is 4. Here there's the VT only 2 need cardioversion, and 2 of them due to prolonged QT interval. The VT due to prolonged QT interval. The rest is, I think there's other etiology like electrolyte imbalance. And then actually one without QT prolongation, and 3 did not survive, and one of the cases ACS. So in summary, cases of COVID in our country is in an upward trend. Our admission had dramatically dropped in March and April, but the trend is start increase once we are able to do in-house PCR, and then also have a dedicated cath lab. And I think with those times, I think we are more prepared to handle a patient with possible COVID. As you can see that the ACS, approximately 20% of our admission cases, COVID-19 has impacted our some ACS performance, especially door to device. Despite that, I think from May to April, we are able to drop the delay from 200 minutes to 120. And the mortality is in ACS patient, I think in comparison to 2019 is similar. As you can see that our confirmed cases is 1.7% out of the all ACS. And then cases in the isolation ward is that confirmed is 17.4%. And then the use of hydroxychloroquine and chloroquine is the mainstay for management of COVID, and is being monitored and evaluated closely in our hospital. With that, I thank you for the time, and I pass it back to Dr. Isman as the moderator.
Thank you, Dr. Dafsah, with excellent presentations, holistic from the emergency to isolation wards. We believe and understand that the continuations of our services in hospital strongly depend on the COVID-19 management in the hospital. I think not only for a hospital, but also maybe the factory, the business. So the COVID-19 management hospital is very important for continuation of our services in hospital. And we also see show from Professor Wang, the Zhejiang Hospital also has the COVID-19 management. And the third topic, we continue about valvular interventions. Of course, harapan kita as the valvular replacement intervention center in the country. And we believe that Sazu Hospital also as the center of excellence for valvular intervention. Professor Wang, we continue.
Thank you. Sure.
Yeah, for your presentations. Okay, please proceed.
Okay. So before I start my presentation, I would like to thank Dr. Juzar for your so wonderful presentation about your department and how do you work during the pandemic of time. It's not so easy. Okay. So especially facing the number of cases still going up. It's a very big challenge for your staff. So now I'm going to do the presentation about the practice and achievement of our innovation center model in valvular heart disease in our hospital. Actually, it's conceptually we set up, not just conceptually, both conceptually and structurally. we set up the innovation center for the, especially for the valvular heart disease. From the innovation center, I would like to emphasize the physician, the question, or the research topic, or the research title, or the research question is coming from the physician. So when we daily we treat the patients, so the question is coming from patient. The question is asked, is provided by the cardiologist or the cardiovascular surgeons. Then we try to establish a network. So depending on the different purpose, research purpose. So usually in our cardiovascular center, we are focusing on the valvular heart disease. We try to recruit this kind of the professionals like the like the basic research scientists, like the epidemiologists, like the material scientists, like the image experts or engineers, all of those, even the entrepreneurs, we try to get their investment. So some we try to include them even into our institution. Some we just contact them, we work with them. So toward our target, focusing on the valvular heart disease. So try to create the patents, innovate the new devices, and load the scientific papers. Try to promote the team of excellence. We had one article talking about our innovation center, the conception. We had the paper published in New England Journal of Medicine Catalyst. Now I'm going to talk about how we push the innovation center to work, focusing on the valvular heart disease. Our research involving so many areas. First, I would like to talk about epidemiology. Back to the 2015, we did a hospital-based epidemiology survey. So we go over the data, the ultrasound, the echocardiography data. We almost done for 140,000 patients data. We can see here different ages. We understand, so among the different ages, how high the prevalence of valvular heart disease, which type of the valvular heart disease. So like the aortic stenosis is absolutely with the increase of age, we get a higher prevalence of the aortic valve stenosis patients. So here's like the aortic valve disease, different etiology may in different age which may have a different etiology, or like the age from 18 to 44, we can say the most are because of the bicuspid aortic valve, congenital bicuspid aortic valve. Some are rheumatic heart disease, but gradually, like the patient older than 75 years old or equal 75 years old, so we can say the degeneration is the most etiology. Then the rheumatic is a little bit, bicuspid aortic valve is a little bit. Besides the epidemiology, we are also doing the basic research or genetic research. We found a genetic, we call the ADAMS5 mutation, strongly related to the bicuspid aortic valve stenosis in Chinese population. So the prevalence of in the population with the bicuspid aortic valve stenosis is much higher than the patient with the tricuspid aortic valve stenosis. We are also tracing several families. We did the family genetic. We did an investigation about the family genetic background. And our studies also is involving the basic science as well. We try to figure out. We use the mice model. We just causing the ascending aorta coarctation, and then we set up the model. Then we do investigation. We try to do some research. We try to understand how to with the contraction of the ascending aorta. So what is going on about the mitochondrial function? So we try to figure out what is the key of the pathway to work for the hypertrophy of myocardium. So we found a very specific pathway is strongly related to the hypertrophy of the myocardium, like the OPA1 expression. If the TNF receptor 2 stimulate may promote the mitochondrial fusion, is not good for the, it's facilitate the hypertrophy of the myocardium. So if we suppress the TNFR2 receptor 2 stimulation, we try to activate the OPA1, may delay the hypertrophy of a myocardium, also may delay the occur of the heart failure. So possibly someday we can try to develop new medications. So besides the epidemiology and the basic research, we try to do a procedure strategy innovation. Like the TIVR procedure is going up very quickly in the whole world, as well as in China. Last year, we almost done, in whole China, we almost done the 3,000 cases. But 1/3, we done almost 1/3. We done about 1,000, a little bit less than 1,000, more than 800 cases. So in China, we meet more patients with bypass aortic valve stenosis, much higher than the Western countries. So in China, almost 40 to 50% of our candidates are bicuspid aortic valve stenosis. However, in Western countries, it's around 10%, usually be less than 10%. If we review the guideline from ESC from ESC 2017, the bicuspid aortic valve stenosis is still not favor the TIVR, but however favor the SIVR. So there are many problems until now has not been solved for TIVR in patients with bicuspid aortic valve stenosis. Even the bicuspid aortic valve stenosis among those patients in Western countries, they have more the type 1 patients, but in our country we have more with type 0 patients. We have more patients with severe calcification. That's a totally different the anatomy pattern. So regularly we following the Western strategy for TIVR procedure. The device sizing strategy is based on the CT scan. First, we use the CT scan to measure how big size of the annula, aortic valve annula. Then we make a decision how big size device we need. So usually it's 5 millimeter, 4 to 6 millimeter larger than the annular size. Initially, we do the same way. We use the same way for patients with bicuspid aortic valve stenosis. However, later we found it's big challenges. Usually, the device we put is too big, especially for those patients with so severe calcification. So like this patient, we follow the traditional way to select the device. The size is based on the CT scan. So when we put the device in, because of the squeezing of the native leaflets, so cause the diving of the device, cause the mobilization of the device down, so cause a lot of the PVL, regurgitation. Occasionally, if you want to have a little bit higher initial deployment, may because of the squeezing of the native valve may cause the jump out of the device. So later on, we found as the key is we have to measure how big the size of the supraannular size. So we use the balloon to do a supraannular sizing, just above the annular. Usually it's around the 10 millimeter. So we say when we inflation of our balloon with the force, at last, how big size of the supraannular structure we can achieve. So we measure this, we measure the waist of the balloon. So then we make a decision how big size device we need. So we call the Hangzhou solution. From our registry study, from our torch registry, we develop a strategy for we call the balloon sizing of supraannular structure, or we call the balloon sizing of the native leaflets. Following the Hangzhou solution, with the 30-day mortality for bicuspid aortic valve stenosis is very low, it's only 1%. Especially the permanent pacemaker implantation rate is so low, it's only 1%. PVL with the first generation device, until now in China, there are only first generation device on commercial. We have not yet got the second generation. We have not yet got the retrievable, repositionable device on commercial. So even with the first generation, the PVL is around, moderate or great PVL is around 9%. It's absolutely acceptable. Now we are working with the multiple centers. Now we are designing a multiple center study and try to answer whether the Hangzhou solution, and try to get the detailed answer about how to work the Hangzhou solution. So we want to enroll more patients with big samples. We want to RCT studies. Then I'm going to talk about the device innovation. Just now I already mentioned we work with enterprises to develop the new device. The first device in China is we call the Dafsah A. It's made in Hangzhou. It's actually back to the 2009 and 2010. My team worked with the enterprise team. We work a lot to design the device. We send our image, a lot of patients' image data. We gradually understand that we have more patients with the bicuspid aortic valve stenosis. May we need a stronger radial force device. So, but the first generation device was on commercial in May 2017, 3 years ago. But it's an unretrievable, it's an repositionable device. Then we work with the company, we develop a second device we call the Dafsah A Plus. It makes the device retrievable and repositionable. So this is the picture. We work with the engineers in the company. We do the initial design, and then we do the animal studies. Then we back to the November 23, 2017, we did the first in-man study. Then we work with the other 3 hospitals, like the Fuwai Hospital and Zhongshan Hospital in Shanghai and West China Hospital in Chengdu. So 4 hospitals we work together. It's chaired by me. We organize a clinical study. We call it pre-commercial clinical studies. So we have done the Dafsah A Plus. We have done 62 cases. So compared with the Dafsah A valve study back to 2017, the Dafsah A Plus is 62, Dafsah A is 101. So we can see here the bicuspid aortic valve stenosis. Here is around almost 70%. But here, venous A, the unretrievable device only less than 40%. So 67% and 40%. So venous A plus the recruit more patients with big challenge cases, especially more patients with bicuspid aortic valve stenosis. Also, the angle, the ascending angle, much higher in venous A plus research population because the study has more patient, more bicuspid aortic valve stenosis patient be enrolled. So among 30%, almost 32% of patients with ascending angle is larger than 60 or equal 60 degrees. However, in venous A studies, only 13% the ascending angle is larger than 60 degrees. However, the composite endpoints we can see here. So for the venous A plus, it's only 16.13. However, in venous A valve, it's 27.7. Doesn't matter. Venous A plus has higher, have more cases with bicuspid, but here is less cases with the bicuspid. So more challenging procedure here, not here, but the composite endpoints significantly lower for the venous A plus. About the retrievable function, some doctors, they are worried about the retrieval function. So if the device, you didn't retrieve, they're worried about the long-term, the function of the device. So we do the analysis about all of those patients are venous A plus patient. However, on the left is for those patients, the doctor did the retrieval. They did the retrieval the procedure. But for this, on the right side, for this kind of patient, we didn't do retrieval. We just put the venous A plus because the position, maybe the initial position is good. So the doctor, they don't change the position. They don't need to the retrieval function. So compare the two groups, we can see for those patients with retrievable function, actually, they are less the PVL compared with the doctor didn't do the retrievable function. Here is more frequent with the PVL. So it means doesn't affect the long term, but the 30-day valve function. Now we, here the yellow column is venous A study. The gray one is venous A plus study. So the blue one is venous A plus with the retrievable function. So we can say compared with the venous A, so composite endpoints and the pacemaker implantation rate, the conversion to surgery. So all of those, the venous A plus has better performance than the venous A. Furthermore, for those patients, they have the retrieval. They did the retrieval function. Even the MACE is lower. And now we are working on the new generation of device we call the venous A pallet. So pallet is not just a retrieval function, but also have as well as we'll have the reposition, flexible function. So we put together a retrieval function and flexible function. We finished the animal study, and last year we did the first in man. Now we are applied for we submit our data, initial data to the SFDA. We try to get approval for the further clinical studies before on commercial. And now I'm going to a little bit touch about the transcatheter mitral valve intervention. Our hospital is a pioneer center for mitral clips back to the 2013. in last year, March, we did in the Asia Pacific region, we did first we did 2 cases about the ARTO system. The ARTO system is actually we put a fixer in the coronary sinus. Then we try to we get a line from the coronary sinus to the atrial septum. We tighten the line gradually. Then we make sure the mitral valve regurgitation already be done enough. Then we try to cut the line. So you can see because the fixer in the coronary sinus is a patent under the X-ray, so you cannot see the fixer here in the coronary sinus. You cannot see the suture line because the suture line is a patent during the X-ray in the end of the X-ray. But you can see the other fixer in the atrial septum. You can see quite clear. It looks like the atrial septal defect occluder. Because the tightened force is not so big enough, so it's not so easy to diminish the mitral valve regurgitation. We still work on the new device. We try to modify it with a team from Israel as also a very strong engineer. They have a very strong engineer teams. So we work together with them. We try to modify the ARTO device. We have done most cases. We started the new procedure, new called in mainland China. Now we did the most cases in mainland China. Since 2000 April, is a new call system. A new call system is good. It's very good for the prolapse, especially in the P2 region prolapse. So we just from the apex, heart apex, try to we put the artificial cortis for this kind of patients. The indication for new cord is quite narrow. It's only for the P2 prolapse. If the other area prolapse, it may not be function well. So the indication is very narrow, but for patient with the P2 prolapse, we'll have a very good outcome. Now I'm going to talk about the mitral line. Back to the 2015, 4 years ago, we did almost 10 PIC studies for the mitral valve regurgitation. We used the mitral line technique. We submitted data to the FDA. We try to get the investment for the device on commercial. However, we have not get the investment support enough. So, but the other in outside China, they start the mitral line to treat the mitral regurgitation. However, it's not so good. So they use the same conception. They use the mitral line conception to treat the tricuspid valve regurgitation, have a very good result. And now I'm going to talk about it's a quite new device. We name it as a Dragonfly. Actually, we work with some medical staff in the United States and one company located in Hangzhou, and we are involving the innovation of the new device. It's different from the mitral clip. It's similar to mitral clip, but not different from. It combines the mitral clip with the Pascal conception, put the two conception together, and we call the Dragonfly. It's our first device developed in whole China, but made in Hangzhou. We did so this Scott Lim actually. I think he's a bigger guy, and he chaired the innovation of the device. The Mr. Zhang is a very young guy. He's an engineer, so we work together. The picture is show you we work together, and we have done almost 40 PICs, 23 for the acute study and the other 17 for the chronic studies. We just keep the PICs on observation for 6 months. Then we sacrifice them to see what is going on. about the mitral valve leaflets. Very successfully, and back to the July 23 this year, just 1 month, a little bit longer than 1 month ago, we successfully did the first case in our hospital. It's functional mitral regurgitation patient with a dilated cardiomyopathy. So quite clear before the procedure, you can see very severe regurgitation. After the one clip, we can see only a mild regurgitation, residual mild regurgitation. So 4 hours after the procedure, the patient can start to working, and next day, the patient be discharged. This is the August 11, we did the second case. We're using the dragon line, we did a second case. This patient is a DMR patient, it's a prolapse, it's an A1 area prolapse. So it's a DMR patient. We put the first clip, it's not working well, it's still a bigger residual regurgitation. Then we put the second device in, so side to side, side by side. So we achieve which is great. We almost diminish the regurgitation. Now we actually then we continuously we did 3, 4, even 5 cases. The last week, early last week, we did 5 cases. So all of them all of those patients are doing very well. Now I'm talking about the tricuspid valve repair. It's close to the time we do the mitral line on pigs. We also did we use the same technique to treat the to do the tricuspid valve, for the tricuspid valve on the pig on the piggers back 2015. Just last month we used a new device. The device is developed by the Dr. Lu in Shanghai, one big hospital. We use his device. We treat several patients. It's an implantation device. Yeah, works very well. But also we are about the pulmonary valve, the venous P valve implantation. This device is already on commercial almost 3 years ago, and we involved in the clinical studies. Now we use the venous P to treat some patients, especially for those patients after the tetralogy flaw procedure. Usually for this kind of patient, they have a lot of the pulmonary regurgitation. So we use the venous P to treat this kind of patients. This venous P valve. Because our hospital, our cardiovascular center is a training center, so we try to we try to expand our program to the other hospitals. We try to do teaching nationally and internationally. So until now, we have went to more than 70 medical centers to do the teaching. So work as a proctor to teach them how to do the timer, how to use the venous A device, and how to use the Hangzhou solution. Also, we went out of China. We went to Greece. We went to Argentina. We went to India. We went to many medical centers. We did a life demo there. Also, we regularly we have a workshop, internationally workshop. So some of the Chinese, they are coming from the different countries to join our workshop. Annually, we hold a meeting. It's the biggest valve meeting in China. We call the China Valve Hangzhou. We just finished the 6th time Hangzhou, China Valve Hangzhou, just July 25th to 31. So it's because of the specific time, we use a webinar instead of the on-site meeting. There are more than 100 global life demo be done, and so many countries and so many famous valve labs, catheter labs, they presented their cases. and deliver lectures and do the live demos. So there are almost 330,000 online attendees. I just give a little bit summary. Give a little summary. Is innovation center model. I think it's a very good model for develop the innovation, for develop the new skills, new strategies, for develop the new device, even for the basic science, and just focus some the area. Like my team and me, we do a lot of angioplasty patient implantation before, but because the structural heart disease is this area is so promising, so I'm just moving on, focusing on the valve disease. So not just do procedure, but also try to do some the innovation. Thank you a lot for your time. I finish the introduction of this title.
Okay.
Thank you.
Thank you, Professor Wang. Very interesting with your presentation, and of course, congratulations for your outstanding achievement developing the advanced technology in heart valve intervention devices from aortic valve, mitral valve, tricuspid, and pulmonary. And of course, we are, as the top referral hospital, Harapan Kota Hospital, of course, very interesting. And the president director, of course, hear and listen these presentations. And we will continue for sharing experience from Indonesia, from our center about the advancing of the transcatheter aortic valve implantations. We have here the speaker, Dr. Doni Firman, PhD. He is the head of interventional cardiology department in Harapan Kita Hospital, and also he was the president of Interventional Cardiology Society in Indonesia. So maybe it will be interesting and tremendous presentation between China and Indonesia. Dr. Doni, please proceed for your presentation.
Well, thank you very much. Good afternoon, ladies and gentlemen. So thank you for the kind introduction. So my name is Doni Firman. I'm working in Harapan Kita Hospital, and now I'm a head of cath lab. And then my duty this afternoon to talk regarding the TAVI in Indonesia. So where do we stand? Of course, I really enjoyed Professor Wang's talk previously. And then it was amazed that your hospital or your country already advanced regarding the valve implantation. And then if we remind, the TAVR was started at 18 years ago in France. We knew that Professor Alain Crivier performed firstly in Rouen. And then after that, we know that implantation of TAVI all over the world. The current United States so they expect in 2025 there will be 280,000 implantation all over the United States. So what about the other region? We know that the European is varying from 10 to 20 cases per million to 160 TAVR units per million inhabitants, like in my slide showing Germany leading in terms of number of implantation per year, and then Switzerland and France. Of course, we know that maybe the next 1 or 2 years, China will be the most implantation all over, comparing to all over the world. And then we know 10 years ago, the TAVR indication just for very, very high risk patients means that the patient who cannot go undergo surgery, proving by Dr. Leon paper, showing in patient who cannot go under surgery, TAVR have a beneficial comparing to the standard therapy. And then 1 year after that, Dr. Smith and all the colleagues also showing that in high-risk patient, meaning that less than very, very high-risk patient, for the high-risk patient, showing TAVI is non-inferior comparing surgical in regards of the death and also the other MACE. And then 6 years after that, we know that also Dr. Martin Leon showing in his beautiful trial, showing that in intermediate risk patients group, also TAVR is non-inferior comparing to surgery. And now we are dealing with the low risk patient. Last year, we know that 2 or 3 trials showing that in low risk patients group, TAVR is non-inferior comparing to the surgical. Means that in this year, starting that every patient with aortic stenosis can be done or can be performed at TAVR if indicated. And we know that the technology also improve year by year, showing that by Professor Wang previously, showing with this amazing system and an amazing modern system, and then the valve and also the shaft is getting less and less. So the complication is also getting less and less in terms of the bleeding complication from femoral access, and also the complication of a pacemaker, and also complication of the PVL. So we are heading to the better outcome in the near future. So what about in Asia? So there is a report that in Asia, so the age around 80 years old. I don't know what about in China, but this is the Asian group reporting the age at 80 years old. In my hospital, I will report later, the age is approximately 72 or 74 years old. And also we know that STS score relatively low comparing the reported from United States and also from Europe. The STS score averagely regarding 5 to 6. And then of course, like Professor Wang mentioned, that bicuspid aortic valve comparing to the European is much more in Asian population. So according to Professor Wang talk that even in China, it will be much more comparing the other region of Asia. So if we notice from the registry of Asia, from the Asian registry, we know that most of devices implanted in Asia is core valve and sapien. Of course, we hope in the next future, so the China valve also can be implanted in all over Asia, and including in Indonesia. So regarding the outcome, you know, the more risk to the patient, of course, logically, the cumulative incidence will be high. And then comparing to the Caucasian, of course, our body mass index will be much less comparing to the Caucasian. And if the body mass index is less, then the complication will be high. So that's a very logical things. And of course, if the PVL or paravascular leakage is more, so the long-term outcome will be not very good. So some reporting by Professor Paul Cham on neurointervention showing that 2 years ago, Japan still have the higher implantation, and then the Hong Kong, Singapore, and South Korea. Of course, I believe that maybe this year China will take over regarding the number. So what about the COVID-19? We already talked about the COVID-19. So it's a strange time for us. So we try to adapt this strange pandemic. And then our group, including me, already launched the clinical expert opinion regarding the TAVR implantation, especially for Asian hospitals. And then we decide that if the patient aortic stenosis and then plan to have a TAVR electively, so we considered to postpone it 1 to 3 months. And if the urgent, so the TAVI can be done in days or 2 weeks. Of course, in semi-urgent, it can be done in 1 month. So this is our recommendation, and then it is published in Journal of Cardiac Surgery 1 month ago. And then, of course, the technique. So we propose that we should maintain the high TAVI standards, and then local anesthesia will be preferred over the general anesthesia, because we still worry about the spreading of the virus. And then we also propose that minimize excessive staff in the room, and don't forget the PPE should be the highest as possible. And then if you have negative pressure, cath lab, so it will be much better. But I believe not all the cath lab has a negative equipment, negative pressure equipment, including in our hospital. We don't have yet. I don't know, in China, you have that kind of luxury. So back to the aortic stenosis, you know, in India, reporting in, let's say, they have an increasing aortic stenosis, because the life expectancy also high year by year. And then if you look report in India, it's almost the same epidemiologic data comparing to Indonesia. The mean age is around 72 years old, same with us. But the STS score much higher, regarding 13. And then 100% root is from femoral root. What of course, you know better what happened in China. So I just, quote from the Professor Chan in CIT last year. I attended the meeting, and he reported the first implantation was 2010. And then in 2019, there was nearly 2,000 implantation in mainland China. And interestingly, you have your own domestic TAVR devices, and then have 6 centers of experience more than 100 cases. It was amazing, and I believe in the next year you have more than this. And like Professor Wang mentioned, that the unique demography of patient in China, that you have so many bicuspid. That's a really challenging topic. And then also you already mentioned that how to deal with the bicuspid aortic stenosis. So what about in our hospital? We did the first in Indonesia in 2015. At the time, we still use a core valve, a non-retrievable TAVR from Medtronic. And then 2 years ago, we already starting a valve in valve. This is the gentleman already have surgery, aortic valve surgery with bioprosthetic, I think 10 to 12 years before. And then came with us with a heart failure, and showing the failure of the bioprosthetic valves. So we decided to evaluate our implantation. And then it went well. The patient is quite stable right now, and then can do a routine activity. So to comparing to TAVR cases in Indonesia, of course, we much slower comparing to China, because this equipment is very expensive. So the reimbursement from the government not covered this kind of luxury. And then comparing to TAVR, of course, TAVR is covered by our national insurance, so the number is still relatively high. Of course, comparing with you is still very low, but we still the highest number of in surgical of IVR in Indonesia. So I just we got a report that average 70 to 150 AVR cases in our hospital. So right now in TAVR, in TAVI in Indonesia, there are 2 hospitals routine doing TAVR, my hospital and Mandistra Hospital, running by Professor Santoso. And then this is, I think it's 2 years ago data. Well, right now we already adding the number, even the number is not very much, but you can see the mean age is 74. So it's relatively young comparing from the other countries. And then also, predominantly male, but we send the patient to TAVR relatively with a good ejection fraction. We not daring to do in low ejection fraction right now, because we're still in learning phase.
And also most of us, all our patients are coming with high STS score. So the result is all of us is elective procedure and 100% by transfemoral approach. Like I've mentioned before, the valve type available in Indonesia, just 2 until right now, core valve and Evolut, both from Medtronic. To the last 2 years, we use a second generation of Evolut R, retrievable TAVR. And then, sorry for that. Oh, cannot back. Okay. Anyway, this is one of our memorable case. This is a 64 years old male, and then came with heart failure symptoms. The problem is that the patient already got CABG, and then coming with us with a sign of heart failure. So the echocardiography showing the still good ejection fraction, but showing also severe aortic stenosis, but AV-FETI around 0.9 centimeters square, and then peak EVG around 51 millimeters square. So patient was diagnosed with severe aortic stenosis with moderate AR. Sorry, can I? Okay. Oh, sorry. Okay. The patient already got a CAT study, angiographic study, and then showing all the graft is patent. And then even the Euroscore is still low, the heart team conference decided to have a TAVR for this patient because the patient already got a CABG, and then our surgeon hesitated to do reopen the chest. So the CT showing that the ideal, it will be 34, number 34, the size will be 34. And then we proceed to the lab with procedural plan as above. So, initially the case is, like our other cases running smooth. So we thought we can do it in rapid way, but then after ballooning, still okay with blood pressure showing very, very normal, and also the heart rate. But then after balloon, after BAV, suddenly the blood pressure was dropped, and then couple of seconds after that, the heart stopped beating. The monitor show VT and VF. So we started CPR directly and give the patient a shock a couple of times, and of course continuing with adrenaline. So, but after 50 minutes of resuscitation, it looked like we not has any progress. So while we're doing CPR, we still discussing. We discuss among each other what happened. So if they're cardiac tamponade, but TE and fluoroscopy confirmed no leakage in pericardium, so that there was no cardiac tamponade. If a coronary occlusion, we did some angiography, not the issue because the patient post CABG and all grafts are confirmed patent before. There might be the patient has acute aortic regurgitation, and arthrography showing that the patient has aortic regurgitation. If you notice the monitor showing that the heart completely stopped when we're doing arthrography, which was terrified. We were terrified at the time, but we must do something for the patient. So we decided just to continue our job and deploy the Evolut R34 while the heart stopped beating, and then continuing CPR at the time. But amazingly, the heart started beating again after 30 seconds, and just nothing happened. The blood pressure coming up, and then we stopped all the vasoconstriction or vasopressor. And then after that, the evaluation procedure, the shine no aortic regurgitation and minimal leakage. And then the patient still seeing me in the outpatient clinic and still very happy. He was a former police officer. So in my summary, you know that as heavy Indonesia is increasing, even the number is not as rapid as China, maybe because we have a problem with reimbursement. So there's not much center who done TAVI. So far is 2 routinely doing TAVI because there's a lack of operators of heart team. So interestingly, we have some problem like demographic of Asian region, the proportion of elderly patient getting high, but not as old as maybe from the Caucasian. And also we're dealing with the smaller Asian physiques compared to the Western population. We are much, much smaller. And then we're still concerned about the dimension of iliofemoral artery. But from the recent system of Evolut R is getting low, even you can go with 14 French. So it's really helping, especially for the Asian population. And of course, for the aortic stenosis, most of patients coming with rheumatic heart disease, so it's not really ideal for the TAVR. And then the most problem is the cost. Of course, that because of the surgical AVR is much less cost comparing to the TAVR. And also surgical AVR still covered by our health insurance, but not TAVI. So I think this is my last slide. Thank you very much for your kind attention. So I'm giving back to moderator, Dr. Isman. Please, Dr. Isman.
Thank you, Dr. Doni. Thank you for sharing experience for Indonesians' experience putting the transaortic valve replacement for the patients. So of course we hear that there is the complications happen, but dramatically, but luckily the patient was alive. We already 2 hours left from start this webinar. So for all participants, can write the question from Q&A, and maybe for the first from Indonesia, Dr. Dafsah and Dr. Doni, maybe you have some topic or questions to the Professor Wang. And Professor Wang, is there any issue that's very important for us? For Taffy from China, origin from bovine or pig? Prof. Wang? Professor Wang.
Hi, thank you for Dr. Firman's wonderful presentation. And I just introduce you to Dr. Liu. He is just coming. So he's my colleague, and we work together for the TAVR program. Okay. I just have one question: is so how much is in Indonesia? How much is the core valve, and how much is the Revolut R?
Dr. Doni?
Okay, so
how many?
Actually, regarding the cost, I'm not fully know, but maybe my director knows better than me. But right now, average the cost of the Evolut are about $35,000 right? So me and Duff implanted the last 2 years we implanted Evolut R. We don't have a core valve right now because we already shift to the Evolut R, which is much more convenient. So the average, I think the last we implanted the cost is for one device around $35,000. I don't know whether your device is much economically compared to the Medtronic.
So in Indonesia, there are any domestic production in Indonesia? There are any homemade production?
No, we don't have that.
Not yet.
So I was really impressed by your hospitals, as how you can, developing new systems. So we don't have yet in Indonesia. So we look like we're waiting for your collaboration with your hospital.
So what is the national training system for the TAVR procedure in Indonesia? So how do you learning this kind of procedures? So there are coming Sentosa, actually we met him. I met him as many times in China meeting, like the CIT and Sentosa.
Yeah.
Okay.
All right. So right now, just 2 hospitals continue doing TAVR. One is our hospital. We are a public hospital owned by the government, and Professor Santoso doing in the private hospital.
Okay.
Okay.
Then, of course, there is some requirement to do TAVR. Not every hospital has a luxury to have that procedures. There's some requirement of the operator, requirement that every hospital have to have a minimal 50 surgical AVR case per year, and every hospital should have 24 hours a surgeon to stand by, and of course every hospital has to have a heart team, solid heart team before the government permitted us to do the TAVR. That's the situation right now. So of course the first 10 cases will be proctoring by the foreign proctor, and then after that we are eligible to do by ourselves.
Okay.
That's how it works in Indonesia.
Okay. So among your 23 patients, how many you put a pacemaker after the procedure? Permanent pacemaker.
Oh, pacemaker complication. Actually, when I forget the data, but when we shift to the Evolute R, the last 2 years, 0. There was no pacemaker. But again, our number is low, so it's you should be careful to extrapolate because the number is low. But as far as I know, the last 2 years we don't have any AV block from our patients.
So one issue I don't understand is why the percentage of the bicuspid is so low.
Okay.
It's comparable with the Western countries. Mm-hmm. So it's a quite the phenomenon is quite different. So I think that you have only 2% of patients for the TAVR are bicuspid, right? Almost 2%.
Yeah, I don't think we have the number in Indonesia. That's 2% is the number in the case that we did. So we only have one case with bicuspid that we did.
Yeah.
We didn't have your data like the echo data from like your country and determining. Actually, I have a question regarding the echo data. How's the valve disease? Do you still have a lot of rheumatic heart disease? Because I think our valve disease mostly rheumatic heart disease, and we are actually not very easy to find patient that's suitable for TAVR. And once it's suitable, usually the financial is the hurdles.
Okay.
你回答
OK，
为什么我们风湿怎么样？你回答。
他说他们那边风湿嘛。
对，他说我们为什么这么多？是不是我们风湿还？
Yeah. So in China, less and less patient with the rheumatic heart disease. Yeah. So in the clinic, we met some patients with rheumatic heart disease, and we have to use the different strategy to do the TAVR procedure. Majority of the patient in our center is the degenerative aortic stenosis and the bicuspid aortic stenosis. Yeah.
China changed a lot. When I graduated from medical school back to the 1983, so during that time, so many rheumatic heart disease patients. Mm-hmm. But since the last 20 years, gradually down. Now it's very rare. Even 1 year, we just met several rheumatic heart disease patients.
Yeah.
So most of patients for the TAVR is either the degeneracy or the bicuspid.
Yeah. Yeah. I have a question for you. Is the bicuspid aortic valve is the contraindication for TAVR procedure in Indonesia?
Yeah, so, no. Actually, yes. I mean, our patient with bicuspid maybe is not as much as your patient.
Okay.
So we have bicuspid is, I think for TAVR, I think 2 or 3 patients. And then when we did our core valve patient, actually we faced with the bicuspid. It's not went well. The patient has complication because we at the time we have core valve, so you know, not retrievable. But the last year, we did some bicuspid patients with Evolut R, and it went well. So there's no complication at all. So I agree with you that the CT analysis, is, especially with supraannular, is very important. So again, that retrievable TAVR is very helpful in dealing with the bicuspid. But again, we're not very sure how many bicuspid, I mean, the percentage comparing to all aortic stenosis in Indonesian patient. We don't have data yet, but okay. I believe the echo department right now still completing their registry right now. So hopefully we can report. But I believe it's not as much as in China.
Okay. Yeah, why I ask this question, because in 2019, Professor Wang's team went to Philippines General Hospital to do a TAVR procedure. So because 2 of patients with the TAVR 0 bicuspid aortic valve were excluded by the core valve or the Evolut Pro, and then we used the Venus A, from the China, and then we do the very successful TAVR procedure for the TAVR 0, patient in Philippines. So I don't know whether this is the situation is quite similar in Indonesia or not.
I think it's not, because it's already been mentioned. It's just more challenging to do. But I also interested in your device. How much does it cost, your device? Especially when you brought it to Philippines.
Still very expensive. I think it's around
30,000.
$30 American dollars.
Yeah.
Less than 30, 28, possibly $28 American dollars.
30,000?
$28,000.
35,000.
Yeah.
So we are searching for the collaboration opportunities. So there are any possible, if we, hopefully the pandemic will be gone soon.
Yeah.
So hopefully we, our team can, is there any possible we go to your institution and we can bring the device free, right?
Yeah.
So there we do the procedure. Is there any possible you can accumulate more patients?
Yes, I think Dr. Iwan maybe want to answer that. The possibility of China team will coming and bringing their own device, and then we try to our patients. So maybe is my boss will answer that.
Okay. Dakota.
Professor Wang, can you hear me?
Yes, sure.
Yeah, I think there is still a possibility in terms of the collaborations between our institutions and your hospital as well. But the thing is that you must submit the regulations to our teams, right? Any trials involving our hospital will be discussed with the ethical committee. When it's passed, I think that we can do that. This is still a possibility, of course, and collaboration between your hospital and our hospital. But the thing that we should submit this kind of the ethical clearance from our ethical team. When it passes, I think that we can do the collaboration study.
Okay. Good.
Okay. Maybe we can discuss for the cooperation for the meeting and for the cooperation between Harapan Kita Hospital and Zhejiang Hospital, because in this webinar attend almost 300, more than 300 participants here, so across country. Okay, so of course the President Director, Dr. Iwan Dakota, very happy, and then should follow the regulations from hospital and of course from the government. So from the Dr. Iwan, is there any issue? We still have maybe the time still 5 minutes ahead.
Yeah, Dr. Isman and
Yeah.
Dr. Wang. One thing that we should know that we have already signed the MOU between Harapan Kita, our hospital, and your hospital. So based on this signed MOU, I think that we can do some collaborations, either for educational, right, fellowship program, as well as for the research.
Okay.
But I think that for the research, if let's say you are interested in to expand the multi-center trials, let's say involving our center, that's still possible, of course, because in our MOU they stated about that. They stated about that, the possibility of the research collaboration.
Okay. Okay, we can work on the MOU first. So we will write something draft. Like you know, the Miss Yang is chief of Foreign Affairs Office. She left already. Okay, the lady before just sit next to me. The Miss Yang will work on the draft. So we send to you. You can revise. Then we couple times maybe we can sign a MOU.
Okay. Sorry, we signed already the MOU last year.
You already signed the MOU. So based on the MOU, we can.
With your
I think we already signed. I signed the MOU already.
So I think as we have MOU, so we can run, and we can you can submit the multi-center trial to our hospital.
Okay.
Then we will go to the ethical committee. Right.
So if you okay, please.
Okay, Prof.
If you agree, maybe we can provide online training for Taiwan. So especially about the self-expanding device and the Hangzhou solution. Yeah. So we can provide the online training if you like.
Okay. I think for next advanced cooperation between Harapan Kita and Zhejiang, maybe need a couple time meetings. So for the next, I think there is the exchange technology between Zhejiang and Harapan Kita Hospital. You can come to Harapan Kita, and of course, Harapan Kita will send a fellow from the hospital to train for TAVR. I think the time is over now, so we can close this webinar meeting. Almost more than 2 hours 20. So I summarize the meeting. So in this webinar collaboration between Zhejiang and Harapan Kita, we put some information from Zhejiang regarding the issue of COVID-19 management, and of course the outstanding development, the outstanding experience from Zhejiang Hospital to develop the device, the heart valve device technology. So we hope Harapan Kita can engage for this development. And of course, Harapan Kita as the top referral hospital, the prominent hospital performing some cardiovascular procedures, will always follow the new advanced technologies. So thank you for the participants, and especially I extend my appreciation to all the speakers, Professor Wang, and all the Zhazhu team. And of course, special thanks for President Director Dr. Iwan Dakota for this collaborative international meetings. Before we close the meeting, we take a pic first, okay? We take a pic, okay? Yeah.
Okay, thank you.
Okay, one, two, three.
Okay.
Yeah. Okay.
Bye-bye.
Okay, now
see you next time.
See you next. So thank you.
Next time.
Okay, next time.